Hello, everyone, and welcome to today's webinar. My name is Thanos Pallidis, and I will be your moderator and speaker during this session. I am a proud HoFH Europe ambassador and a representative of my national patient organization in Greece called LDL Greece. The topic of this webinar is understanding our lab results and knowing the numbers. And I'm very pleased to be joined by a fantastic panel of speakers representing patients and care perspectives, as well as the perspective of researchers and clinicians who see patients like us every day. Together with Emma Broome, joining us from the UK, Gergely from Hungary, we will share our personal stories, which we trust will help we put the research and some of the numbers and definitions into context. This will be presented by Professor Mafalda Bourbon from Portugal, Professor Maciej Banach from Poland, and Professor Michal Wramblik from Czech Republic. I'm sorry if I killed it with the names. We hope at the end of this webinar, you will feel confident and empowered to understand better with testing your levels regularly is important. What different TERS number and abbreviations mean, how to interpret them, and what steps to take the best care for yourself and your loved ones. Knowing and understanding your numbers might be the best step to preventing any consequences of undiagnosed health issues. For those of you joining us for the first time, this webinar is the second one out of 4 webinars under the umbrella of HoFH Europe Ambassadors Training. The previous one was dedicated to explaining the FH pediatric screening. The following ones are dedicated to Lp(a) and FCS. Now, HoFH Europe is a network of patient organizations across wider Europe. There are 29 organizations in the network. As a community, we are committed to advocating for supporting people living with inherited dyslipidaemias like FH, homozygous FH, elevated LPA, and FCS. This session is aimed at raising awareness and increasing health literacy among our patients community internationally, lay public, as well as developing patient ambassadors. Now, we would love to know more about our audience. So please write in the chat who you are, where are you joining us from, and what you hope to learn today. While you do that, I would like to share some housekeeping rules. This webinar is being recorded and will be available on demand on HoFH Europe's YouTube channel, where you can also watch it with subtitles in your local language. It's also streamed on Facebook. If you have any questions, do not hesitate to post them in the Q&A or on Facebook live stream, and we'll try to answer as many as we can live in the same Q&A section. Please avoid any specific questions related to anyone's personal health records or treatment, and that would be much about it. So let's start then with Emma. Emma, would you like to go first and share with us your story?
Thank you, Thanos. My name's Emma. I'm based in the UK. I'm 43 now. I didn't get diagnosed with any condition until I was 33. So I grew up in a household where it was my mum and my dad and myself, and we'd always had a pretty healthy lifestyle. My dad got diagnosed with high cholesterol when I was 11. However, at the time they thought it was controllable by diet. And it was. We never had any issues. His cholesterol went down, everything was fine. I got tested for cholesterol when I was 23. At the time, I had a boyfriend from Italy, and his dad was a doctor. And I asked him to test because at the time in the UK, they weren't keen on testing people sort of under 40, really, for any form of high cholesterol. And my cholesterol turned out to be 8.4. And his dad sensibly put me on a diet straight away. And then when I was back in the UK, I told my doctor, and he said, oh, you've got no need to worry, you're fit, you're healthy, you do a lot of sport. And as a female, your estrogen levels will protect you until you're well into your 50s. And so I didn't really think much about it. However, I now know that's not necessarily true. And also that links back to a webinar HoFH Europe produced, I think on the 22nd of September, called Living with FH and Being a Woman. So come forward another 10 years till I was 33. I've been living a life that was normal for me at the time, and I still am, a chef on a luxury yacht. So traveling around the world, doing sport. I do adult gymnastics. Last year I sailed across the Atlantic, and just carrying on. We took a sabbatical. My husband and I were skiing in Canada at the time, and I got the most tragic phone call in my life, that my mum, aged 66, had passed away from a heart attack. It's the most devastating news I'd had. And obviously we dropped everything, flew straight back to the UK. My GP then went, oh, okay, so did test me for cholesterol. It was still 8.4. I got put on statins straight away. I got asked at the time if I wanted to have genetic testing. I said no, because I was traumatized by the death of my mum, because we were very close. And I couldn't really see any benefit because we didn't have kids. I'd also been told that it can put up the price of health insurance, travel insurance, mortgages. So at that time, it was a big enough step for me to go on to statins and be told I'm going to be on these for the rest of my life. And so, I carried on with that, and going from having no medical issues ever to suddenly having high cholesterol and being on statins, at the time it took a lot of getting used to for me. I was taking it at exactly the same time every day. I was worried I was going to drop dead from a heart attack, to be honest. And, that might seem a little bit over the top, but I was so scared. And in 2016, so 3 years later, we relocated. I had a different GP. We were due to do a circumnavigation on the yacht. And my GP said, wouldn't it be lovely if it turns out you don't have genetic cholesterol, and so you don't have to go and pick statins up when you're traveling around the world? And I was like, yeah, okay. So it's almost like I was being bribed, but it seemed like a good bribe at the time, until I then found out that I have FH, so familial hypercholesterolemia, and lipoprotein little a as well. So as Magda, who heads up HoFH Europe, said, I've hit the jackpot. So yay. However, I've had brilliant support over the years from Heart UK, which is the cholesterol charity back in the UK, and I carry on doing what I'm doing. So I still compete in adult gymnastics. I have a competition a week Sunday. I've just got back from working on a yacht in Greece, and I don't let my conditions rule my life. I now take ezetimibe as well as statins, and yeah, I'm doing okay. I kind of figured the conditions that I've been born with, and yes, I understand, of course, that they can get worse as I get older, but I'm still going to continue with what I'm doing for as long as I can. And with the tragic loss of my mum, I always look at the fact that she saved my life, because if we hadn't known that, if she hadn't have passed away, I wouldn't have been tested and I wouldn't have known this. And but fortunately, it seems that the rest of my family haven't been impacted. So either that or they've chosen not to be tested. So it really is just me. And now, having had it, the diagnosis for so long, I'm fine with analysing the results. But again, at the time, looking at the test results, it's like, well, what is HDL? What is LDL? What is the ratio? What are the measurements for LP little a? And fortunately, I've always had great support, great cardiologists, etc., who've been able to explain it to me. And I've been tested over in the US, and the measurements over there are different to what they are in the UK. And then in the UK, they can also vary, particularly for Lp(a), according to which area you're in. So it can be a bit of a minefield, but there's always people there to support you.
That's a very powerful story, Emma. And considering that you're a professional chef and an athlete, it must have been really hard for you to take away all these misconceptions about the inherited condition of FH and LDL. I mean, how did it feel for you when you realized that it doesn't only matter that you are in a very good physical shape, and you had to shake all these misconceptions that people were telling you? Did you fell from the sky, or?
Well, I mean, to begin with, you're absolutely right about the misconceptions. Most people, I am super tiny, and most people say, well, you can't possibly have high cholesterol because look at the size of you. And I'm like, well, yes, but when it's genetic, it's got nothing to do with your size. So I find a lot of it is education, and helping others to understand that, yes, you've got dietary cholesterol, which of course is related to your lifestyle, but there's so many of us, as you know, that it's genetic, and it's not down to what you eat. But of course, I mean, we still have to eat healthily, we still have to exercise, but genetic cholesterol, so FH, Lp(a), etc., can impact anyone, no matter what your size, your shape, where you come from, what you do. And education plays such a large part in it.
That is very true, and it is very inspiring to also see that you have turned all the way to be an active advocate of faith right now. And now let's go to Professor Banach. Can you help us understand why Emma's story is so important for our community?
Well, first of all, I would like to kindly welcome all of you. It is a great pleasure to meet you all, especially that we usually meet in a very boring societies associated with only physicians, and it is much better to meet with you. So if you allow me, I will share with you some of the slides in order to better understand what is important and what is not important concerning the lipid profile. And on the other hand, I would like to kindly stop me if I will talk in a medical language. I try my best to be very easy with the message, because it is critically important to be easy with the message. But if I fail, please simply push me on my head in order to avoid such a situation. Okay. Emma's story is great. Why? Because Emma showed that it is not so easy to reduce the risk of cardiovascular events, because in Emma there are two conditions that might increase the risk. It is high cholesterol, high LDL cholesterol, because it is the one which is the most atherogenic, which is associated with the atherosclerosis progression, and also another risk which is associated with lipoprotein(a), which is completely independent to all other risk factors. But in order to say that it is not so easy, please have a look that we usually manage with patients with completely different, with many different other risk factors that may cause residual risk factors. Something which might be, if we are even on the target with LDL cholesterol, and we are over the target with obesity, we are over the target with glucose level in patients with diabetes, still those patients are at the risk of cardiovascular events. That is why we need to have a kind of comprehensive approach to all risk factors. What is important if we look at the lipid profile? Please have a look that first of all, we have a total cholesterol, all the particles you can see here. This is a total cholesterol. If we exclude HDL cholesterol from all those particles, we have something which is called non-HDL cholesterol. And for non-HDL cholesterol, these are all particles which are critically important for the atherosclerosis progression. So this is critically important to remember that if you look for those particles in lipid profile in the lipidogram during the measurement of lipidogram, please always look on the LDL cholesterol and non-HDL cholesterol, because these are critically important. Obviously, if you have such a possibility, please have a look that on each particle there is apolipoprotein B. So that is why it is much better if there is such a possibility to measure apolipoprotein B, because also on lipoprotein little a, as you can see, there is also apolipoprotein B. So apolipoprotein B, in fact, reflects all the atherogenic, so related to atherosclerosis particles that are important to the progression of the atherosclerosis and increase of the risk. Someone may ask about the HDL cholesterol. In fact, it is so complicated issues associated with the fact that, in fact, HDL cholesterol is important only for healthy patients. And we are during the patients with FH, with high level of lipoprotein little a. And in those patients, most of the particles are dysfunctional. So they may play the same role like LDL cholesterol in order to make this view easier for you to understand. So do not look for HDL cholesterol in your lab measurements. But let's little bit focus next on the on those lipoproteins and what should be the correct level of those lipoproteins. It is critically important first to evaluate the risk of the patient we have in our office. So that is why we have different models. It is less important for you. But if we look at those risk factors that are included in those models, please have a look. This is a blood pressure. This is a smoking or no smoking status. This is a gender issue, because this is a completely different risk for women and for men. And non-HDL cholesterol, I've mentioned it at the very beginning. It is so critically important to remember about it. And based on this, we know, for example, that these patients may be at a low, moderate, high, and very high, and even extremely high cardiovascular risk. From 2019 guidelines, we know very well, for example, that patients with FH at least high cardiovascular risk, because those patients usually have LDL cholesterol over 190, and that is why we know very well that those patients should be treated as those with at least high cardiovascular risk. But on the other hand, we also know that in 99% of those patients, these are patients at a very high cardiovascular risk. What is more, if we look at these relations of the risk categories to the LDL cholesterol levels, please look that for low LDL cholesterol, we usually have suggested indicated level of LDL cholesterol below 115, 3 millimole per liter. It is if you may ask why there is some confusion that in some countries there is milligrams per deciliter, in some countries there's millimole per liter. It happens indeed. Obviously, the most correct unit is millimole per liter, but in many countries, for example, including Poland, we use milligrams per deciliter. So that is why in all the guidelines we use 2 units in order to avoid any confusion. So both units are okay for LDL cholesterol. For moderate risk, we have 100 milligrams, 2.6. For high cardiovascular risk patients, we have 1.8 or 70 milligrams per deciliter. And for very high, those patients should be below LDL cholesterol level below 55 of 1.4. There is also some patients we might consider as extremely high cardiovascular risk. For example, these are patients who after acute coronary syndrome with FH. Taking into account the results from different trials we have, we know that those patients should be at the lower, the better for longer with LDL cholesterol, and the earlier on LDL cholesterol goal, the better. So that is why for those patients, in fact, we do not look for the targets, because we know that for those patients, we should be as low as possible. One more, if we look at the ranges for each categories, please have a look that total cholesterol, in fact, is now only used for non-HDL calculation, because the non-HDL calculation is a total cholesterol minus HDL cholesterol. It is less important for us because we know that it is a much less predictive biomarker in comparison to LDL and non-HDL. For a non-HDL cholesterol, please remember that these are almost the same values like LDL cholesterol plus 30 milligrams per deciliter in order to better understand those goals. So for example, if someone is at the risk below 70, so at high cardiovascular risk, it should have non-HDL cholesterol below 100. So it is critically important to remember this relation. For lipoprotein little a, it is also important to remember, because we know it is based on the Polish guidelines, because in the recent European Atherosclerosis Society guidelines, this still approach that all patients should be over 50 milligrams per deciliter or 125 nanomole per liter. And again, there's a little bit confusion concerning the units. Please remember that here, the only correct value that presented the number of lipoprotein little a particles is nanomole per liter. But due to the different methods we use and test in the evaluation, that may happen that the results will be milligrams per deciliter, and this is the reflection of the mass of the particles in our body. But the most correct is nanomole per liter, and it is critically important to remember. And finally, it is in order to say you more about these results, the genetic predisposition that Emma showed you. It is one reason that we know that the high level of LDL cholesterol and the high level of lipoprotein little a is since the birth. But there are also something that's the primary reasons of hyperlipidemia and hypercholesterolemia and dyslipidemia. But there are also some secondary reasons we always consider when we have patients at our office. And we all should remember that these are some drugs. And please have a look at some of the examples of these drugs, because this number, that there are a high number of different drugs that might affect the level of both LDL cholesterol and triglycerides. But also there are some diseases: hypothyroidism, chronic kidney disease, nephrotic syndrome, obstructive airway disease, HIV, autoimmune disorders, pregnancy, polycystic ovary disease, and many others. It is worth remembering about it that sometimes our level of LDL cholesterol might be associated with the secondary reasons. For example, please remember that for triglycerides, they are very sensitive to diet, and that is why we should measure triglycerides, and only triglycerides, fasting, non-fasting, in fact. But for other units, it is not necessary to be fasting, and as we should be for triglycerides level, because in fact every diet might increase the level of triglycerides by even 30%. So this is a very sensitive biomarker. Or what is more, please remember that also age is associated with the changes of lipoprotein level, because over 75 years of age, we might observe, for example, that the level of total cholesterol, LDL cholesterol, is usually much less in comparison to those patients below 75 years of age. So that is why it is critically important to remember. And pregnancy is another great physiological approach in which we might observe 2.5 more level of triglycerides and about 30% higher physiological level of LDL cholesterol. And my last slide, this is my results, because I don't want to show the results of my patients, in order to show you how the results might look like for total cholesterol. My apologies, it is in Polish. And as I've mentioned, these are the levels in milligrams per deciliter, but obviously there is no problem at all to have two units in this lab results. But also for HDL cholesterol, as I've mentioned, it's less important. For LDL, it is measured with the direct method here in our laboratory, but we have at least few methods by which we might measure. And obviously the most accurate is the Martin Hopkins formula, but it is less important for you. Triglycerides, the ratio of HDL cholesterol and total cholesterol, non-HDL cholesterol. And based on these panel, we might say about the risk, we might say what is the expected level of reduction for the patients at the concrete cardiovascular risk we measure at the very beginning for each patient. Hopefully, I bring you a little bit more information, and this message is much more clear, but I'm at your disposal in order to explain you more. Thank you so much.
Thank you for making it so easy and understandable, Maciej. And you know, it's for a patient to hear about two different units. The first time I went to a congress and I found out that there is also the mmol per liter method. I didn't know actually if that translates, you know, to what level it translates to the cholesterol measured here in Greece. I was so confused. I didn't if you asked me back then, I couldn't know to name my cholesterol level per mmol per liter. And as you mentioned, it has so many layers and so many different ways you can form your the treatment, the optimal treatment based on the LDL level specifically and the total cholesterol. As it happens, I'm also diagnosed with FH, with the severe form of FH, the homozygous form. And I would like to talk a little bit about that. Some of you may have heard my story before, but in any case, I will give you the short version of it so that we are on time. So it all started on 1993 when I was 3 years old. And even at this early age, I have already developed xanthomas on my elbows and on other parts of my body. And my family, concerned as they were, took me to a dermatologist, thinking this is a skin condition. And my first prescription at that time was a gel I have to apply on my skin, on my xanthomas, every day, and I was told not to worry much about it. When it became apparent that the xanthomas won't go away like that, my parents took me to a public hospital, and the doctors there found out that my total cholesterol was 5 times the maximum normal. It was only then that my father recalled that he also had a cholesterol check a few years ago, and his total cholesterol was also abnormally high for a 33 years old man. But due to the misconception that high cholesterol, at a young and healthy individual is just not possible, and without any professional guidance at that point, he disregarded this information as invalid. So for me, back then it was a big back and forth between HCPs here in Greece. And you have to know that back in the day, not many were educated about FH. And since we didn't find any clear solution, we were trying to find another routes. We have managed to find a contact with lipid clinic in the United States, and I got there my official diagnosis as an HoFH patient. And I also had my first genetic test there, which was very unusual concept in Greece at that time. All this new information about being an HoFH patient and all this genetic and all this new information was simply overwhelming for us. But going there was potentially life-saving for me too, because after we returned to Greece, we have reached the public hospital where I live in Thessaloniki, and we found the HCPs that they were willing to collaborate and learn from their colleagues and the lipid specialists from the lipid clinic in the United States. From that day on, I started receiving the available treatment at that time, which they were based and regulated upon the findings of my cholesterol levels on lab result, like Maciej said before. And then doctors would go on and adjust my treatments based on the findings on the latest cholesterol lab results I had. Long story short, I'm 32 and happy to be on a very good condition right now. But a long time has passed ever since when I was first diagnosed. The medical community has become more aware, and the scientific advancements throughout the years have been growing rapidly. And it seems that the genetic testing becomes more and more relevant in the context of FH and HoFH, as having genetic results can help, for example, with the choice of the most appropriate treatment, or gives clues about how certain treatments will help us. So we are heading in the direction of personalized medicine. It is therefore my pleasure to bring Professor Mafalda Bourbon to explain more. The floor is yours, Mafalda.
Hi, everyone. Thank you, Thanos. I'm very happy to be here with you all and I will try to explain a little bit of your genetic reports and your genetic results. It's a difficult subject, so please tell me if you think that I'm talking as well too much of scientific language. Let's see if I'm good at sharing my presentation. I hope you can see the presentation now, right, Thanos?
Yes, I can. It's
Okay.
clear. I think that
Right.
everybody can see.
So I'm a researcher. I work at the National Institute of Health, and I'm head of the Portuguese FH study. And I develop research in FH for more than 20 years now. So I'll try to speak about 4 or 5 parts of genetics that are more important. So one thing that is very important is that everyone knows that FH and most familial dyslipidemias, they have a biochemical, a clinical diagnosis. So all of them have a biochemical clinical diagnosis, and some of them have a genetic diagnosis as well. Of course, we know that some countries it's not possible to do genetic diagnosis, so clinical diagnosis, biochemical tests are okay to diagnose all these disorders as well. So genetics gives you more information, but it's not the first identification. The first identification is always through the clinic. So in this table, I just wanted to show you that familial hypercholesterolemia, for example, you can measure LDL values, and with other history of your clinic, your family history of hypercholesterolemia and heart diseases, you have the clinical diagnosis. But the genetic diagnosis, you have to sequence at least 3 genes: the LDL receptor, ApoB, apolipoprotein B, and PCSK9. So these 3 genes should appear in your genetic testing if you're testing for FH. And if you have a report, and I'll show you a report afterwards to make it easier, if the report says that one pathogenic variant is found, so you are diagnosed with heterozygous FH. If the report says that you have 2 pathogenic variants, and if that is tested and you know that you inherit one variant from each father, one father, and from the mother, you are diagnosed with homozygous FH. So this is the basic concepts for the genetic diagnosis of FH. For Lp(a), you don't have a genetic diagnosis for now. I don't know if anything that we can develop on the genetic side, if it's going to be better than measuring. I'm sorry, I just see that I had here a spelling mistake, so it should be Lp(a) values. Probably measuring Lp(a) values will be always better for diagnosing a hyper Lp(a), but we'll have to wait a bit more so we know more about the genetics as well. And for familial chylomicron syndrome, that's another disorder that FH Europe supports as well. So you have to measure the triglycerides and have other clinical history to have the clinical diagnosis. But then if you want to get a genetic diagnosis, you should have the sequence of 5 genes: LPL, ApoC2, LMEF1, GPI-HB1, and ApoA5. So this is a recessive disorder. So it's not like FH, that it's a dominant disorder, and you can have heterozygote and homozygote, depending if you find 1 pathogenic or 2 pathogenic variants. In FCS, it's a recessive disorder, so you always have to inherit 1 variant from the father and 1 variant from the mother. So it's always necessary to have this. Just overview of the genetics of FH. So I know that most of you know that there's 3 genes associated to FH, so the LDL receptor, ApoB, and PCSK9. And I'm going to continue this today, speaking more about FH, because we have, like Thanos said in the beginning, we have other webinars dedicated to Lp(a) and to FCS. But I'm happy to answer any genetic questions about those other disorders here or in another time. But today I'm going to focus on FH. So you can have these mutations, very pathogenic variants in these 3 genes, and the majority of FH patients have a variant in the LDL receptor. So more than 90% of the patients have a LDL receptor defect. ApoB and PCSK9 are very, very small percentages. And also what I wanted to show you, there's different ways of doing a genetic diagnosis. Before we had to sequence each gene alone. So we have to sequence first the LDL receptor, then the ApoB, then the PCSK9. If it was negative, the results of the other genes. But now we have this very strong methodology called next generation sequencing, NGS, that you may have heard. And that allows us to study more genes at the same time for the same price and for the same time of the report. So this is a huge progress on genetic diagnosis, that we have this NGS methodology that we can study panels. So for example, in my lab, an FH panel, we study not only on the 3 genes causing FH, LDL receptor, ApoB, and PCSK9, but we also study other 5 genes that are attributed to another disorder that can mimic the FH phenotype. So these patients also have high LDL and a high LDL in the family, but they are recessive disorders. So usually the parents, they don't have such a high LDL as the parents of FH patients. So this is this is panels that can help you diagnose more than one disorder. And for hypertriglyceridemia is the same. You have more genes here. You have 9 genes in this panel, and some are for FCS and others are for other causes of hypertriglyceridemia. So I think it's important as well to discuss a bit the importance of the genetic diagnosis. Emma talked a little bit that the beginning, when she had the diagnosis, she didn't thought that the genetic diagnosis was important. And I can understand the reasons for her to think about that. But I can say from the scientific point of this is very important to have genetic diagnosis. First, it confirms the clinical diagnosis and defines if you are a heterozygous FH or have homozygous FH. Then it tells you which gene is affected. It can have an impact in your treatment. The most recent findings is that the type of variant that you have can add very important information for clinical use, for treatment. For example, we know that patients with an LDL receptor variant that leads to a short protein or no protein at all, so that the ones that stop variants or frame shifts, I know this is very difficult terminology, but maybe some of you have heard about it. So these kind of variants, they are associated with a very high LDL values with a higher presence of early onset cardiovascular disorders. So these patients should need a more intensive treatment, and they should get it because they need this to avoid early cardiovascular disease. And this is what we call personalized medicine. So every day we are coming through this path to personalized medicine, that every patient will have through their own variant, their own lifestyle, the only environment, will have a more personalized medicine towards that single patient. So this is like a report should look like, a genetic report. So it should be 1 page, and in that page you should have a short description of the test, of the methods of the test, the results, and the interpretation. There's some labs that can give you extra pages, but that extra pages are more specific details and are for the the clinician to interpret. Let's see the better genetic diagnosis. So this is a genetic report for heterozygous FH. Of course, it has your name, it has the sample ID and the dates where it was received and report date, and has the physician name as well. So this report, the genetic report, always goes to the physician. It cannot go directly to the patient because these are very, very difficult to interpret reports. So it has to go to the physician, and the physician has the obligation to explain the report to the patient. This is like this in Portugal, and I think it is probably around the world. There's this rule that it has to go always to the physician, so the physician explains to the patient. So that what is important for us, for example, in the lab, is to receive the indication for testing. So if the clinician wants a FH test, and why the clinician has an FH test. And for example, this case here that I invented, 220 milligrams of deciliter, and the index patient, the son with high LDL as well. So I know by these numbers that I'm probably looking for a heterozygous FH patient. So this helps me with moving on with the genetic testing. Then it comes the methods. So the methods, of course, is going to be difficult for you to read out, but the important part is for you to read which genes have been analyzed. And you can see here that it's the 8-gene panel that I showed you before. And then you have the most important, the results. So the result will tell you which gene has a variant, if any, because you may know that in 50% of the clinical FH patients, we don't find a variant in one of these 3 genes. And the reason for high cholesterol can be another monogenic disorder, can be polygenic, can be environmental. It's still on doing lots of research on those FH negatives. But the ones that have a variant associated, so you can see here that you have a C dot and then a number, that's the position in the DNA, and then you have a P dot, and that's the amino acid in the protein. So here the patient has a variant, an alteration that changed one amino acid, glutamine for lysine. And this is important for them to do the part of the interpretation. So in the interpretation part...
sorry, Mafalda, to interrupt. We're a little bit ahead of time. How many slides do you have left? Sorry.
I think 2 only.
Okay, you can go. Just be a little bit mindful.
So yes, I'll do it very quickly. So in this part of the interpretation, you have lots of difficult parts, but they are more for the clinician. And what you have more important here is the classification of your variant. So this is a likely pathogenic variant. And this is very important because the likely pathogenic variant is going to confirm your FH heterozygous status. So that's the yellow part here. So that's another part that you have to be very careful to look at your classification of the variant. And if it says that it confirms your diagnosis, then it says other important parts like genetic counseling and cascade screening for relatives. If it's a homozygous report, you'll have exactly the same kind of report, but then the results you're going to have that have a homozygous variant, and it's the same variant, or you have 2 heterozygous variants. And here it's very important that both parents are tested to confirm that you have a homozygous FH, because you need to make sure that one variant comes from the father and the other one from the mother, and not the 2 from the father. 2 LDL variants from the father, for example, is not a homozygous FH. So this is my last slide. This is just for you to know that when we classify variants, we have to fulfill a guideline that is international guideline, and we have to say if the variant is pathogenic or likely pathogenic, and those are reported on your report. Then you have variants of unknown significance. These variants, they don't confirm your diagnosis until you have more evidence, but some labs report these and some don't. So always look at the classification, because a VUS, a variant of unknown significance, does not confirm at the time your diagnosis. So this is the most important message. And this is because the only actionable variants, so the ones that can make a difference in clinic, is the pathogenic and likely pathogenic variants. And I know we are behind in time, and I think I said enough. This is lots of information. I'll be happy to answer any questions and do another webinar if it's needed. So I'll get back to you, Thanos.
Thank you, Professor Bourbon. That was a very good explanation of how the genetics work and why it's so important to have genetic testing. And I really liked the part when you explained about the personalized medicine, about how different LDL receptor variants have short protein or not at all, and how would that affect them differently when it comes to the treatments, even if they are, they have the same or similar mutations to other patients, and how different they actually are when it comes to treatment. So moving on to Gergely, who is a fellow patient and an ambassador. and who also happens to be a father to a boy with FH. How does what you have heard so far concern you? And how relevant is it for parents to know the numbers and to be able to interpret them, to take care of themselves as well as for their kids? Over to you.
Thank you, Thanos,
There you go.
and thank you, everyone. So actually, it all pretty much relates to me that has been said so far. I just discovered that Emma's story is pretty similar to mine on some levels, because my story is I'm an attorney at law. Basically, I was living my life my busy life as an attorney, and because of a totally unrelated test, it was some dermatologist test. It was very simple. I didn't really want to go to the blood test, but it was a full blood test, including cholesterol, and that was the time I was kind of diagnosed with high cholesterol level. It was of course a no-go for the doctor treating me with this skin problem, but it was unrelated and nothing to do with this whole. But she was of course aware that this is a very high level of cholesterol. I was around 30, just like Emma told us, and then I turned to the GP. The GP says, yes, this is high cholesterol level. We need to treat it with statins, with the usual standard treatment. And you know, this is how Hungarians are, you know, fatty food and everything. Although I didn't really eat fatty. I know there are very delicious Hungarian dishes, but I'm not that kind. But I was not aware. I didn't really get the lab results. I mean, yeah, it's a number, it's higher than, you know, it has that little asterisk next to it. Yeah, I got that it's higher than the standard, but whatever. My GP said that my, let's say, condition is high cholesterol. That's a kind of a disease or a definition. I didn't really get it. But yes, I took the pills. I mean, she prescribed the pills. I got the pills for 10 years long. And that was, yeah, and my numbers were quite okay, more or less okay, I would say. I had no idea that there is a condition called FH or whatever. And the next big surprise came when a similar story happened with one of my sons. You know, FH is typically 1:2 ratio inherited by your children, by our children, and that's the actual case in my life. So the real big surprise came when a similar story happened with one of my sons. There was a typical thing. Oh, this little guy is too pale, said his GP. Let's take a blood test, maybe the iron or something. It was in February, so logically everyone is pretty pale in February, here at least. So we took the blood test. The iron was okay, but his cholesterol level was again very, very high. And then that GP, so the child GP, was instantly aware that this is familial hypercholesterolemia. So it's a family inherited thing. Then it's not just fatty food. It's not just bad luck of the family. So she instantly called. I mean, word by word, she instantly called our professor who's treating the kid now, and that's how we ended up, actually both of us ended up having a proper diagnosis, because I wasn't really aware what I have and what I need the pills for. It was just high cholesterol. But then with my child's diagnosis, I instantly realized it. What is it? And of course, it gave me an extra boost to have more information, have more insight into this condition, and then I again jumped into the local FH association called Heart Failure Hungary, and then FH Europe. So most of the information I got and most of my insights are coming from our organization. That's why I'm pretty much involved in it and pretty much enthusiastic. But it's very important to know that this is a familiar thing. This is inherited, pretty high percentage that it's inherited, and that is important to test our children as soon as possible, because the other positive thing is that as soon as my child has been diagnosed, first of all, he has all the life in front of him. So he has many time to adopt, first of all, with the diet, right from his, actually, he was 4 years old, so very young. So he can have a complete life with the right diet, with healthy food, with healthy lifestyle, which he does actually, and of course with some pills, and he has perfect LDL levels since his almost early childhood because of that. And the other important thing is that as I knew my child's diagnosis, then it was basically my diagnosis too. So that's why it is important to let's say this kind of testing, because once you find a child or a parent, you basically find a whole family of FH.
That was very interesting to hear, Gergely, and I can relate to your story too. And I think that all the three of us, fellow patients, we have very similar stories as to when we got our first lab results and the misconception about our age and our lifestyle, and why would that, what would that be besides high cholesterol. But in any case, it is very important for a father, and maybe it is the turning point, I guess, because I'm not a father, that when you realize that your kids have the same condition, have the same disorder, and actively doing something about it. And this is very fascinating. Now, we will move on to our final speaker, Professor Vradlik Michal. You're a clinician who sees a lot of people with FH, some with homozygous FH, and with elevated LPA. What do you have to add to this webinar? What's your take on this?
Well, Thanos, thank you for the word, and thanks for organizing this very nice and rare event. I do have to share the idea of Maciej that we typically meet in group of experts, but this is maybe much more exciting and more important, basically, to see patients and to discuss what you feel is relevant. I'm based in Prague. I work at the largest lipid clinic in the city center. And throughout our over 50 years of history, we've seen many thousands of homozygous and heterozygous, of course, many more heterozygous FH patients. And I do see a lot of them. And I must say that basically you have answered all the questions that I may add to this topic, because your experience is typical. It's simply what the patients typically go through. The disbelief, and unfortunately, we still see it also on medical side. And believe me, we've been doing a lot to overcome this barrier. So it's diminishing, but basically the disbelief that young individual, even a child, may suffer from high cholesterol levels, and that it must be something related to lifestyle, something manageable with lifestyle only, which is not true. Fortunately, as Mafalda has very nicely alluded, now we have the genetic testing available, and fortunately, it's widely available throughout Europe. So basically, the confirmation of the diagnosis is now much more readily available. And I believe all the three of you have been genetically validated, genetically diagnosed. when the genetic diagnosis is made in one family member, it could easily be made in all the others. So the pedigrees can simply be tested and we can recognize the carriers of the disease versus non-carriers of the disease. And it's important, as Mafalda said, also because at every level of LDL cholesterol, the patient who has the genetic disease has approximately 5 times greater risk of heart attack. It's interesting, but it's the way the evidence has taught us. So it's really important to really understand what type of hypercholesterolemia you suffer from. And this is basically something that we discuss with our patients very frequently. As this webinar is focused on interpretation and understanding lab results, I have just one maybe funny experience. When you look at your blood work results, I believe that they vary, they are different, you know, slightly, but they are different. Some of my patients get quite obsessed about very tiny little differences. They say, oh, my LDL cholesterol is no more 70, it's 75 milligrams per deciliter. Or it's no more 1.8, it's 1.85 millimolar per liter. So guys, don't get disturbed. Labs are accurate, but not as accurate that you might fancy. So basically, when you read these tiny little differences, you are still in very safe range. And this is something that we always emphasize to our patients. Don't be upset when you read your slightly higher level, which is higher by 5 milligrams per deciliter. This is the inaccuracy of reading, and single reading is nothing. We need to follow trends. And as you all strive to live with, as Maciej said, as low LDL as possible throughout your lives. So basically this tiny little fluctuation makes no harm if you fluctuate around very low level of LDL cholesterol. So this is just my comment. Don't be scared about fluctuations. These are normal as fluctuations of blood pressure and blood sugar. Simply all the values are not written in stone, but when you fluctuate in tiny little range that is around the optimum, the goal value, then everything is fine. Thanos, I don't really know whether you asked me about LP small a. I guess it deserves just another separate webinar because it's a pretty difficult topic. But apparently even the audience of tonight is very familiar because all my colleagues have mentioned LP small a as something that's communicated easily. And I find this communication has only started recently, at least in our environment. And I believe this is a good tip for the organizers of tonight to have just a separate meeting on LP small a, because that's just, a whole new story.
Thank you very much. There will be one. If I am correct, it's the last one or the one the next week. In any case, thank you very much for your input. And as you're a lipid specialist, pretty much, I would like to know, to comment about the general knowledge about the inherited lipid condition of the primary medical society, medical community. Do you think they are aware enough? Do you think there should be improvement, should be more educated, the primary clinicians?
Thanos, I'll be very brief. Basically, it differs region to region, country to country. And I must say we are not satisfied with the general knowledge, but it has improved tremendously. So nowadays, I believe that most of physicians are aware of the genetic conditions like FH. Most of them know what to offer their patients, but of course, there are exceptions to the rule, and there's some work ahead of us. And you patients can help because you can know yourself and you can point out, doctor, this is not simple high cholesterol. This might be FH. Just test me.
Thank you very much. That is very true indeed. And even though I would like to comment more about that, I think that we have run out of time. So I would like to thank you very much for everybody involved and also the chat with their many questions. And before we finish, I would like to invite you to the upcoming webinars happening the next 2 weeks. And you can see already the links to register in the chat. And I would also like to help us, advocate for early FH screening. You will find the link in the chat again of the plaque declaration. You can read it and also endorse it if you want. So thank you very much, everybody, for joining. We hope you find it interesting and informative, and we'll see you next week.
Thank you.
Super. Goodbye. Goodbye, everyone.
Thank you. Bye-bye. Thank you.
Bye-bye.